Hello everybody, welcome back to Neuroscience. Today we're going to go through the cerebral vasculature. So the brain requires a lot of oxygen, blood, and glucose. It's very sensitive to pH changes. And there's a loss of consciousness in 0.7 seconds if there is an acute arrest of circulation. This is why pulmonary edemas or pulmonary emboli are so dangerous. So it requires 17% of your entire cardiac output and 25% of your oxygen supply. So in a stroke patient, this is the most common cause of death. The internal carotid artery has a lot of branches. The important ones that you need to know are the ones that supply the ear, the eye, and the posterior communicating and the anterior choroidal arteries. These are the ones that feed into the genu of the internal capsule and the anterior and middle cerebral arteries. The internal carotid goes directly into the middle cerebral artery. It's just a connection. It's a direct path, right? Everything else is just a branch. How do we find it? We find it in the carotid siphon. So this is it. It's just this like curvature. And the vertebral arteries, of course, supply the vertebra along with the meninges, and it feeds into the posterior inferior cerebellar artery, and there's some medullary branches there too. The basilar artery has a huge pontine supply, so it supplies a lot of the pons themselves. It has the labyrinthine artery, and more importantly though is the supplying of the pons in the midbrain. It supplies a little bit of the posterior medulla as well, but it leads directly into the circle of Willis, and then from there the circle of Willis basically disseminates the blood throughout the brain, thanks to the central and circumferential branches. The anterior cerebral artery will arch over the corpus callosum, and it's going to provide like the midbrain along with like the superior part, and the superior external part of the brain, and like all of the internal midbrain right there. The middle cerebral artery, however, is going to supply most of the forebrain, right here, like the lateral sides, while the posterior cerebral artery is going to really supply the temporal lobes and the occipital lobe. The Hebner's recurrent artery also is going to supply the caudate lenticular nucleus and the anterior limb of the internal capsule. So as you can see here, it is quite small. Okay, so circle of Willis right here, it's going to have the branches to basically everywhere in the brain, and more importantly, it's a circle, so it's going to be able to provide the brain with oxygen even if any of these branches are occluded. There is like a circumferential way of providing blood to the brain. So the middle cerebral artery is going to be in the periphery of the brain, right? So they have the lenticular striate arteries, which are your end arteries. These are going to like branch from the communicating arteries, so the middle cerebral artery, and just like worm their way into the brain to supply it. So they are the most important vessels at the base of the brain, because there's a lot of like important tracts there, structures there that need a lot of blood supply, such as the cerebellum and the pons and the medulla. So infarctions in these areas will usually cause like it's usually going to cause a contralateral hemiparesis. Okay, so the posterior cerebral artery, once again, really provides the back of the skull or the back of the brain. So there's going to be some cerebellum branches along with occipital branches, pontine branches. So like it supplies a lot of the brain. The intraurinal capsule is going to be made out of the anterior limb, the geno, and the posterior limb, and all of that's going to be supplied by the middle cerebral artery. Lower parts is going to be supplied by the Hebner's artery. The geno is going to be supplied by the internal carotid artery, along with the posterior communicating artery. The posterior limb is going to be supplied by the anterior choroidal artery, which also supplies the sublentiform and the retrolentiform area. So remember, sublentiform, that is going to be hearing, and then retrolentiform is going to be involved in vision. So the anterior limb is going to carry fibers from the pons to the frontal lobe through the thalamus. The geno is going to contain the cortical bulbar tracts and the upper motor neurons to the head and the face. Posterior limb is sensory. The sublentiform, once again, is I misspoke. Sorry, the sublentiform has to do something with hearing, and then the retrolentiform is vision. Unfortunately, easy to mistake, like myself. The thalamus and the hypothalamus. Okay, once again, thalamus is a huge relay station for all the sensory and motor information. It's going to be supplied by the thalamo-geniculate and the thalamo-perforate arteries. All of that comes from the posterior cerebral artery. Hypothalamus is going to control the basic metabolic functions, and that's going to be supplied by the anterior circumferential artery and the posterior cerebellar artery and the posterior communicating artery. And rarely do these places really have strokes. The corpus striatum is going to be supplied by the middle cerebral artery. Corpus striatum is made of the lenticuliform nucleus and the caudate nucleus. It's going to supply the nucleus and the putamen. And the anterior choroidal artery is going to supply the globus pallidus. The majority is mostly supplied by the posterior communicating artery. So as you can see here, here's the posterior communicating artery, and here feeds in all of these. Here's the internal carotid artery, middle cerebral arteries, so all these little branches coming out. Okay, so the veins of the brain are superficial, so they don't follow an arterial pattern. They run in the subarachnoid space. More importantly, there are no valves in them. So if there is a bacterial infection like meningitis that somehow gets into the spinal cord, it can easily go straight into the brain because there are no valves. It has free reign, basically. So very dangerous conditions. The important veins to consider are the deep Rosenthal veins, the great Galen veins, and all of that basically drains into the straight sinus, and eventually that leads into the inferior jugular vein. The blood-brain barrier is a junctional complex. It's going to prevent the large molecules and charged molecules from entering, except for at the circumventricular organs, which is the thalamus, and the area postrema. So the blood-brain barrier cells are your choroidal epithelial cells, and they're all bound together by these tight junctions. So that prevents the large molecules from entering. There's the endothelial basement membrane, along with the processes of the cells inside. And then there's also more endothelial cells, so it's like a 3-layered blockade. Okay, so part 2, strokes. For each minute, 2 million nerve cells die, and 15 billion synapses are basically like winked out of existence. and all of that leads to about 7.5 miles of neurons die. What does that mean? Strokes are pretty serious. We have to do our very, very best to prevent them from even happening. But this also shows how the human brain is able to kind of like recover from these injuries. Back in the day, physicians and scientists believed that the brain couldn't regenerate itself, but actually, like, the brain can. Not like 100%, but there is some kind of limited regeneration potential. Okay, so what is a stroke? There's two types. The cerebral vascular accident, which is going to be a sudden loss of neurological function due to the lack of blood flow to the brain. This is the symptoms last more than 24 hours, so get you in the hospital whenever you feel like the fast symptoms happening. So the face is numb, the arm is numb, especially like the left side. There's like stuttering, and then time. So if these symptoms come on very fast, like, get yourself to your hospital. A transient ischemic attack is going to be all those symptoms, but that only lasts about 5 minutes. It resolves in 24 hours. So a lot of the times patients don't even go to the hospital. They just kind of pass it off as a brain fart. But this is something pretty important because almost half of the strokes occur within 72 hours of a transient ischemic attack. So if you have the you suspect a symptom of a TIA, take a baby aspirin, and go to the hospital. Unfortunately, there is a predilection to ethnicity or like certain ethnic groups. The ones most at risk are African Americans, Hispanics, and Native Americans, in particular the males, especially males with a history of hypertension and males who are like middle-aged. So the causes can be varied. They can be due to thrombosis that will cause the ischemic necrosis, or no, sorry, not just necrosis, ischemic infarction, an aneurysm, which can be, it can burst, and that can be leading into a hemorrhagic stroke. And those generally occur at bifurcation, and they are either saccular or fusiform. So the most common low-Berry aneurysms of the circle of Willis is usually the anterior communicating artery, because the walls are very, very thin. This is actually lacking one of the layers of endothelial vessels. The next up is going to be your middle cerebral artery. This is just due to the huge amount of bifurcations. The posterior communicating artery is also at risk, along with the basilar tip. So this is a lot more rare, but it's still there. A stroke in the circle of Willis is going to cause hemiplegia. Okay, so anterior communicating artery occlusion will cause contralateral hemiparesis and hemianesthesia, mostly in the leg and the foot, because it provides blood to the frontal lobe and the parietal lobe. So remember, parietal lobe is your motor cortex. And thanks to the stroke in the frontal lobe, there's going to be an inability to identify the objects correctly, change in personality, so there's apathy, and there's usually some kind of confusion involved. Okay, so middle cerebral artery occlusion is going to cause contralateral hemiparesis and hemianesthesia, mainly in the face and the arm. Unlike the previous, this is going to be characterized by aphasia. You're going to also have homonymous hemianopia, which means tunnel vision. There's going to be a defect in the lateral fields of vision and defects in hearing. The cerebral thrombosis is most common here because it's a direct continuation of the internal carotid artery. Another common place is the Charcot's artery, which supplies the basal ganglia and the anterior limb of the internal capsule. So it's due to these tiny little aneurysms of the Charcot-Bouchard's like veins, or the lenticulostriate arteries. Okay, so posterior cerebral artery occlusion is going to cause the contralateral homonymous hemianopia, and that's due to the lack of blood flow to the occipital and the temporal lobe, along with the midbrain and the thalamus. So there is going to be contralateral. So if you have a stroke on the right, you're going to have the left homonymous hemianopia. So it could be with macular sparing or without. So sometimes the field of vision in the middle is normal. The visual nausea is going to be due to the impairment of memory, because there's a problem with like the coordination and the relay of the sensation, and the association and memory recall problems due to the stroke in the temporal lobe. So in these patients, everything that they see is going to be like seen for the very first time. There's no stored memory. They're just gonna they're just going to say words and hope for the best. Okay, so the subarachnoid hemorrhage is mostly due to the Willis involvement, and that's usually due to either an angioma, a contusion, a laceration of the brain, or meninges, and that's like some kind of like trauma and whatnot. There's going to be a sudden severe headache, along with stiffness of the neck and loss of consciousness. All the brain injuries really are characterized by nuchal-rigidity, such as like meningitis and whatnot. Like everybody's like, oh, stiff neck, right? Oh, but why? So the thing is, whenever there is damage or infection, the body's response is to release cytokines. These cytokines are a double-edged sword. So on one hand, they promote inflammation. The inflammation is going to recruit more like leukocytes and macrophages to come and fight the oncoming like invaders. Those are going to secrete even more cytokines, which calls and activates even more like immune cells. So this might activate your cytotoxic T cells. Mast cells will degranulate. So all of that causes a massive amount of inflammation. So everywhere else in the body, you can just swell up and get hot, except for the brain. All of this is going to be enclosed in your cranium, which does not stretch. So the compression of the brain structure is going to cause the nuchal-rigidity, or the neck stiffness, along with the confusion, the delirium, the fever, and etc. So how do we know? Well, how do we differentiate if this is going to be an intracranial hemorrhage or meningitis? We are going to get a lumbar puncture, and we are going to analyze it. And intracranial hemorrhage is going to result in blood in the CSF. And if you can't get the CSF from the spine, it really should be the spine. The last like kind of ditch place where you can try to get it is from the cerebral medullary cistern. So this is like right in the skull, like back of the skull. We really do try to get it from the back, but in some patients, especially morbidly obese, I think there's a new category for it now. I think it's called super morbid or super obesity. But anyway, anybody with a BMI over like 45, it is very difficult to try to have a lumbar tap. So you can consider a cerebellomedullary cistern tap instead. Okay, so the intracranial hemorrhages is usually caused by a rupture of the lenticulostriate arteries, because they're very small and they're very fine and delicate. And usually those will damage the corticonuclear and the corticospinal fibers in the internal capsule. It can be caused to hypertension, atrial fibrillation, and that can result in a pure motor stroke. So that's going to result in the contralateral hemiparalysis of the limbs. There's not going to be any dysphagia or visual changes. The upper motor neuron signs are going to be present. So there's hyperreflexia. The Babinski sign is going to be positive, along with spastic paralysis. The other type was the mixed sensoromotor stroke, which is going to be your hemiparalysis, along with some kind of sensory loss, whether it be pain or temperature. It depends on the level of the lesion or like contusion. So it depends, right? But all of these is going to be characterized by a lack of visual changes or aphasia. So epidural hematoma is going to be blood above the dura. Subdura is going to be blood pooling below the dura. Subarachnoid is going to be within the brain. And then the intracerebral hemorrhage is like right direct here in the brain. So, of course, having a stroke is bad, but of all the strokes that you can have, the better one is a hemorrhagic stroke, because the body can regenerate with what's there, right? The blood is there, nutrients are there, the scaffolding and the tools and the material are there. The body can reconstitute the blood. In an ischemic stroke, however, that part is just dead now. There's no coming back from it, and there are no supplies. There's no nutrients, and there is no recanalization that's possible. Okay, so a subdural hematoma is usually like banana shape. It's concave, and is usually due to the bridging veins. So the bridging veins are these like little veins that are like they're pretty fragile. They are within the subdural space. They kind of sneak through the dura. So the dura is made of like all these little trabecula, right, of collagen or fibrin, and these tiny little veins like kind of snake through to provide blood to the outer surface of the skull. So the epidural hematoma is going to be convex or lemon shape, and it's usually due to a damage of the middle meningeal artery due to some kind of like blunt force trauma to the side of the head. This is going to be characterized by a lucid interval, and then all of a sudden the patient is going to have a blinding headache, and they're going to stumble and then have the photophobia. But before that, like if they have, usually this is in like children that play baseball without wearing a helmet, and they get whacked on the head by either the ball or the bat, and they kind of walk it off for a little bit, and they say like, "Oh yeah, I'm fine." For a little bit, and they act and they talk normally when they go home, and then all of a sudden they just like have ataxia out of nowhere, and then they're blinking a lot, and they complain that it's too bright outside, or there's a ringing in their ear. So if somebody gets like hit in the head very hard, and you suspect that there's something going on there, a lump has formed, get them to the hospital. Don't go home. Don't go and wait for the lucid period to pass, and then they get into that kind of confused state, because the faster you get treatment, the faster you can heal. So like I said, the symptoms are going to be dizziness, headaches, nausea and vomiting, and sleepiness. That's it for now. Thank you for your attention, and good luck studying.